minutes, and we'll start promptly at 3:30. All right, we're going to get started. Good afternoon, everyone. My name is Patrick Stone. I'm the Director of State Government Relations for the National Psoriasis Foundation. Thanks for joining us today, which hopefully will be a great conversation and webinar about step therapy and our efforts in Maine. LD 1407, which we're really excited about getting this campaign off the ground. So our agenda for today, I'll start by talking about the coalition and the purpose of this webinar. Then we'll have a dialogue about step therapy and what it is. We'll talk about LD 1407, what does it do, and where it came from. We'll discuss the history of the issue of step therapy in Maine. It's got a robust history. We'll talk about some lessons learned from other states, and then we'll talk about what you can do to help. I should note a couple things before we get into the meat of the agenda, and that is that you can enter your questions in the chat, and then Amy Prentice, who's assisting with me with this, is going to send them to me. So as we get towards the end of the presentation, I'll be taking a look at the chat to see what questions were asked, and we'll have a time for me to answer those questions. It's also worth noting that in the handout section, there are a number of things I'll be referencing throughout the presentation, and they are there, including the presentation itself, in the handout section. And that finally, a recording of this will be sent to you afterwards, along with those documents. All right, let's get started. So the purpose of this webinar really is to educate and empower and engage not only members of the local Maine coalition, but those of you that may be listening live that are not a part of the coalition and wish to join, or those of you that are, say, a patient advocate or a physician that wants to get involved. So we hope it serves that purpose. The coalition in Maine is co-led by myself at the National Psoriasis Foundation and ACS CAN. And many of you know Hillary Schneider at ACS CAN that covers the state of Maine for ACS. So we thank ACS for their partnership on this issue. Other coalition members include the Arthritis Foundation, MS, the U.S. Pain Foundation, NAMI, Hemophilia, and the Maine Consumers for Affordable Healthcare. And we have over a dozen more that are a part of the coalition. So as you can see, we have a wide range of both physician groups and many people within the chronic disease space. So what is step therapy? We're going to get into that in a second, but a little bit of a plug for NPF's website, www.steptherapyinfo.com. We would encourage you to visit the site to get more information about step therapy and see some of the press and blogs we have posted. We post at least 2 blogs a month and keep the press section updated so you can see what's going on in the step therapy campaigns across the country, not just in Maine. So step therapy, or fail first as we refer to it, is a utilization tool that health insurance companies use to control the order in which a patient takes medication. So you'll go to your doctor and you'll work with your doctor to determine what medication is best for you and your individualized treatment plan. You'll go to get that prescription fulfilled, and the insurance company will say that you are subjected to step therapy and that you must first fail on a number of different medications. So which diseases are step therapy applied to? Well, really, all of them. And so we have a lot listed here. Obviously, psoriatic disease, cholesterol medications are often subjected to step therapy, mental health, diabetes, HIV/AIDS, hepatitis, cancer to a certain extent, heartburn, ulcer, high pressure, the list goes on and on and on. Rare diseases as well are often subjected to step therapy. It's hard to find a disease state that won't be. How does step therapy affect patients? We'll get into that a little bit more on a personal level, but under a step therapy, a patient must try one or more medications before chosen by their insurer before coverage is granted. And one or more is really understating it. In many formularies, we're seeing up to 3 or 4 steps before the patient can get back to the medication that was originally prescribed. So if you can imagine, if you're a patient watching this video and you're thinking about your treatment regimen, and say you're on a biologic that's given, say, every couple of months, once a month, or every couple of months, depending on the biologic, it could take upwards of a year for you to get back to fail on up to 4 medications and get back to the medication that was originally prescribed to you. By that time, you're getting into a new insurance year and maybe subjected to the same step therapy protocols once again. So imagine you go through 10 months of step therapy, you get the drug that was prescribed to you, you become stable, and then you enter a new plan year, and guess what? Subjected to step therapy again. Our bill would hopefully solve this issue. So we know step therapy is on the rise. Data that you'll see here is from 2013. We know that from 2005 to 2013, the amount of step therapy policies or policies including step therapy went from 27 to 67%. Again, this data is a little bit old. We know that that percentage is a lot higher right now. It's probably somewhere closer to the 90th percentile. I think it's also worth noting at this point that this is one of the documents that's included in your handouts. There's a lot of data points here, right? I'm not going to go through each one, but I would encourage you to take a look at them. Some of these are a little bit specific to psoriasis, and I'll talk about that. We know that 48% of our patients, psoriasis and psoriatic arthritis patients, are subjected to step therapy when they go to get a prescription filled. We know that 39% of those people end up having to file an appeal, and that 52% fail to receive that originally prescribed medication. I think this last data point is very important, particularly to our physician advocates, and that's it, that each appeal process for step therapy takes upward of 2 hours of time for the staff in that doctor's office. This is one of the major complaints we hear from physicians, is about the amount of time and money and staff that go into these utilization tools and the appeals process. Not only step therapy, but prior authorization and other utilization tools that insurers use. So we know that doctors are essentially losing money and time that could be spent on patients, providing more care and individualized care to patients, more literal time in the doctor's office with the patient. They're instead spending that time on writing letters, managing their administrative staff, the list goes on and on. So these are a lot of data points, but they don't illustrate the real patient voice. And so I wanted to highlight a particular patient voice in the psoriasis space, and this quote came from Melissa, who is an NPF advocate in the state of New York, and was heavily involved in our successful step therapy campaign in New York. That bill was signed by Governor Cuomo on New Year's Eve. It was a great New Year's Eve gift to everyone. And Melissa is a medical student and a former ballerina, and has a really great story to tell. So she said to us, step therapy allows payers to practice medicine without a medical license. When I tell you that I cannot walk because of my pain, you do not have the right to tell me that you understand my disease more than my doctor and I. You do not have the right to say that you are protecting me by choosing alternative medications for me. I thought that was really well written by Melissa. And she did a great job of writing editorials to papers in New York. And this quote was actually pulled from a response that was sent by an opponent to the bill that was a little bit harsh towards Melissa. I can tell you that many of you know that you shouldn't upset a chronic disease patient advocate. They're one to be reckoned with. So how does an appeal currently work in the state of Maine? I think that's important to understand. these processes are different in every state, obviously. So currently, patients, consumers, physicians of healthcare can request an appeal with their insurer, and there's a link there that goes directly to the Bureau of Insurance website that explains this process. And in Maine, it's particularly arduous internally. Now, this is all internally within the insurer, between the doctor or patient and the insurer. There's a reconsideration. There's a first level appeal of a step therapy or utilization tool denial, and then a second level appeal. Now, this process will vary from insurer to insurer, but the Bureau of Insurance currently allows this process internally alone to take upwards of 76 days. I can't stress that this is even before you get to the idea of an external appeal. Our bill will address this, and we'll get into this a little bit later, but this time period in particular is something that is of concern to those living with a chronic disease, that for particularly for those people who becoming stable and treating their disease consistently is very important to them. So if they're given a drug that's going to keep them stable and keep them healthy and keep away their other comorbidities, having to wait 76 days to get back on that drug is very detrimental to their care. And again, specifically in the area of biologics, if you go off a biologic, we know from data that the efficacy when you come back to that drug, there's a significant chance it'll be much lower. The next step is an external appeal, and that process is conducted by an independent external review through the Bureau of Insurance. Now that is actually paid for. This independent external review is operated through the Bureau of Insurance, but is paid for by the insurers, and the insurers pay per review. Now, this process can take upwards of a month, and the process itself is pretty vague on the Bureau of Insurance webpage. In fact, if you click that link, again, it'll take you to a page, and it'll say, to have an independent external review, click here to contact us for more information. So another level of bureaucracy before you get to that end game. We know from other states that 30 to 40% of appeals of a utilization tool or a formulary exemption that go to a Bureau of Insurance or independent review, 40 to 40% of them are overturned in favor of the patient. Now, this shows that there's a necessity for further protections, right? And we'll get into this a little bit later, but a lot of the things that the insurance companies will say is we've already got a process internally for this. This process works, and there's no need to adjust it. So if you were to go to a legislator, and this is something you can use, and I'm getting ahead of myself, but I think it's important to mention, if you go to a legislator and the legislator says to you, the insurance companies told me they've got this under wraps, and there's no need for this bill, and there's no need for further protections. Your response to them can be to give them kind of an antidote and say, well, look, if you could give me a number of the amount of external reviews that get overturned in favor of the patient, what would be acceptable to you? And they're likely to give you a number that's within some sort of kind of polling margin of error between 4 to 7%, and then you can hit them with that 30 to 40% number. It shows the necessity for the protections. So let's define the problem that we've kind of gotten to already, right? The appeal process, both internal and external, the entire process itself is way too long. Rejections are often made based on preferred drug status. That's something to touch on here. Again, we'll see that step therapy protocols within a given state differ from insurer to insurer. Well, that defeats the argument that they're based on medical necessity or clinical guidelines. If that were the case, then the step therapy protocols would be the same across the board, except for minor instances and differences. Instead, what we know is that they're really based on year-to-year preferred drug status. That's why for a given insurer, they change year-to-year. Peer reviews are conducted by doctors outside the applicable field. So one of the things we hear from a lot of our patients in multiple disease states is that when they get a peer review, when that first initial stage of the appeal occurs, right, they're not getting a doctor most of the times that's in their field. So we've had psoriasis patients tell us that their doctor calls up And the doctor they're end up talking to on the other end of the line is a gynecologist. Well, a gynecologist obviously has no place making a decision about a dermatological issue, yet that's who the insurers end up employing to make these decisions. The protocols for setting step therapy guidelines is consistent, as I mentioned, lack of transparency and consistency. The guidelines themselves are not based on the most current data and aren't using all of the data out there. They're pretty restrictive in the type of data they use. We'll address that a little bit when we talk about aspects of the bill. And the appeals process as a whole is inconsistent, and doctors really lack leverage. And this bill really strives to give them that leverage. So what is the solution, right? And where did this solution, this bill, this model language come from? Well, the State Access to Innovative Medicines Coalition is a coalition of these groups and others that are here on the screen that formed about 3 years ago to tackle healthcare access issues, specifically step therapy and out-of-pocket costs. And this organization has formed model language that has been tweaked over the past few years. The step therapy bill in Maine is the result of a long process. It's a finely tuned piece of model legislation. And so we really strive to find a model bill that wasn't, say, specific just for the rheumatology space or the cancer space or the psoriasis space. We wanted to make sure to craft a bill that would help all people with not only a chronic disease, but really anyone that's ill that is somehow subjected to step therapy. I think that's sometimes something we forget. You know, chronic disease patients are oftentimes used to navigating the system, but if you're someone that's just becoming ill and having to utilize your insurance, imagine you're surprised when you're subjected to these utilization tools. So we ended up crafting model language, and Maine has been a targeted state, and we're excited that LD 1407, which is linked here and is attached in the handouts, has been dropped. It's sponsored by Senator Kimberly Rosen. I'm going to pause here and just let you guys all take a look at this list of co-sponsors and kind of obviously think to yourselves what this represents. So if you're familiar with Maine politics, this co-sponsor list really represents both a bipartisan swath of legislators, but really people I would say are in the right committees, are in the right points of leadership, and may even have the right relationships with the executive branch. So it's important that we put together this bipartisan and I think leadership-heavy support for what we see as really a common sense issue. And I'll get into the common sense mentality of the issue and how it's been reflected in our campaigns in other states here in a little bit. So we've got a bill. What does it do? Well, the bill focuses on 4 main areas that I think you'll see address some of the issues we've identified as a problem. Clinical review. We've got a section on clinical review and making sure that that utilization tools are based on the most current data. We'll get into that more here in a second. Transparency, as we mentioned. Timelines for our response. And then really the real heart of the bill, although all parts are equal, really, I think. And that's defining the overrides. And that's where we're really giving the doctors the leverage back to make decisions that are in the best interest of the patient. So the clinical review aspect of the bill, again, I would encourage you all to really dive into the actual legislation itself and to read the bill and familiarize yourself with it. There are differences between this bill and bills in other states, and we'll get into that more here in a little bit, but it's important to be very familiar with the bill in Maine. So the clinical review aspect of the bill, step therapy protocols should be grounded in clinical evidence, be based on peer-reviewed publications. And this section, I think it's really important to note, we have a part of the bill that says nothing in this section of the bill requires anything new to be created for the state or the insurers. One of the arguments we heard before we had that section was that this section constituted essentially a brand new commission or panel for the state to set up for state health plans, et cetera, and will require a new process for the insurers as well. And that brought up arguments of a fiscal note being added, and so this paragraph in the bill specifically targets that. The step therapy protocol should be developed and endorsed by a multidisciplinary panel of experts that manages conflicts of interest among the members of the writing and the review groups. I can tell you the insurers really don't like that part. Are based on high quality studies, research, and medical practice. Are created by an explicit and transparent process. Are continually updated through a review of new evidence, as I previously mentioned, research and newly developed treatments. And this is a new section, shall take into account needs of atypical patient populations and diagnosis. I know our friends at NORD, who focus on people with a rare disease, particularly had some passion for that language, rightfully so. I want to walk back to the review of new evidence, research, and newly developed treatments. You know, for organizations like NPF that are currently working with our med board and other organizations like AAD to update guidelines for the treatment of psoriasis and psoriatic arthritis, it's important that when we put in that work, which takes years, that insurers take that work and use it and recognize it as fact and put it into their utilization tools. So it's important that we codify this particular language, so when that hard work is done, we can go back to the insurance and say, hey, saw your new utilization tools for step therapy. Think you may have missed out on all these new guidelines that say you're kind of a little bit behind here on treatment of psoriasis. Transparency. So when coverage for a prescription drug for the treatment of any medical condition is restricted for use by an insurer, health plan, or utilization review organization through a step therapy protocol, the patient and prescribing practitioner shall have access to clear, readily accessible, and convenient process to request step therapy exception determination. So again, we'll get into a little bit more of this later, but so the arguments you're going to hear against this aspect of the bill is going to be, well, we're already doing that. We've got a web page up. Trust me, we're telling people about these things. And I think the counter argument to that is particularly for some of the big insurers where we can go in and see, yes, to a certain extent, they are providing this information, although it may not be as transparent as we want, is to point to the bad actors. So we know that you're doing it. Thank you for your transparency. Appreciate it. But there are other bad actors out there that are not following this to the letter of the law or to an ethical standard that we believe is high enough. And so we need to codify this to make sure that that is followed up upon. So again, following up on that, step therapy process should be easily accessible on the insurer, health plan, or utilization review organization's website. I would encourage all of you as we prepare for, and I'll say it now, the hearing on the 25th, and for further meetings and lobby days on this issue in Maine, to start looking at the insurers' web pages. Start looking at the PBM's web pages if they're the ones that are controlling the utilization tools. Some insurers look to the PBM to write their utilization guidelines and tools, and some insurers do it individually. Start familiarizing yourself with that data and what they're putting out there. So the timeframes, as we discussed right from the beginning, these timeframes currently and the amount of time these appeals are taking is unacceptable. And frankly, the 76 days just for the internal process in Maine is one of the worst I've seen in the country, and they're pretty explicit about it. So what the bill does is say that the insurer, health plan, or utilization review organization, again, we're capturing PBMs in there, shall respond to step therapy override exception requests or appeals within 72 hours of receipt and 24 hours for exigent circumstances. Should a time frame, and this is very important, should a response not be received within that time frame, the exception or appeal shall be deemed granted. So if they get caught up in their red tape and they don't respond to the appeal in a good period of time after the doctor's provided the information they need, it shall be deemed granted. This part of the bill is really important. Timeliness of care, staying stable on your medication is very important. We have negotiated this part of the language in other states to come into line with prior auth standards in that state. So that is a possibility. We've also negotiated this to business days rather than hours. So there is some flexibility here. I say that specifically, some flexibility here. But the important part is that we're really whacking down that time, whether it's at 5 days or 3 business days or 72 hours. We're cutting it down from the 76 days, and trust me, that'll have a huge impact on all of our patient communities. So the real heart of the bill here, the overrides. And I underlined here the opening sentence of the bill in this aspect, because I think it's very important. It's really the leverage that's involved. A step therapy override shall be granted if. That means if one of these are met, it shall be granted. I think that for those of us that are in state government relations, the difference between shall and may is a huge thing. And we've had some insurers in other states very casually in negotiations say, oh, I just want to change that one word from shall to may. Yeah, no, we're not doing that. We're a little bit wiser than that. But that's the real leverage of this aspect of the bill, shall be granted. So a step therapy override shall be granted if the required drug is contraindicated or will likely cause an adverse reaction. I think that's pretty straightforward. If you're going to have an adverse reaction or it's going to cause physical or mental harm, an override shall be granted. The required drug is expected to be ineffective based on the known clinical characteristics of the patient and the known characteristics of the prescription drug regimen. So if we can take a look at the drug and know it's going to be effective based on the clinical characteristics of the patient, if we know they're going to have an adverse reaction or we know it's going to be ineffective, a override shall be granted. The patient has tried the prescription drug under their current or previous health insurance or benefit plan, or tried another prescription drug in the same pharmacologic class or the same mechanism of action, and such prescription drug was discontinued due to lack of efficacy, diminished effect, or adverse event. What does that mean? Tried and failed. You have tried that drug in the past and you have failed on it. Furthermore, while under a previous or current plan. What does that mean? That means if you're on another plan and you switch to a different insurer, say because, I don't know, the insurer leaves the exchange or leaves the state, you're covered. You've tried and failed that drug before on another plan, you'll move to a new plan, you shouldn't be penalized. Worth noting, in the same pharmacologic class, we have evidence that shows that in certain instances, stepping through, say, something that addresses the same part of the immune system, there are multiple drugs that address the same part of the immune system in several of our disease spaces. If medical evidence shows that it's not a good idea or they won't be efficacious for you to take multiple drugs after you've failed on one in that class, you shouldn't be told to do so. In many instances, we see upwards of 3 steps in the same pharmacologic class. That's just nuts. And frankly, it doesn't make sense to the insurer. Why would they grant you coverage of that drug? It's only costing them more money. Anyways, I digress. The required prescription drug is not in the best interest of the patient based on medical necessity. We often get arguments from insurers that this is the broadest part of the bill. I don't think medical necessity is broad. I think medical necessity is very well defined. In fact, it's defined in current statute or in the bill in most instances. So we stick to our guns on this 9 out of 10 times. The patient is stable on a prescription drug selected by their healthcare provider for the medical condition under consideration while under a, again, current or previous health insurance or health benefit plan. Patients being stable is probably one of the biggest drivers, something that can drive down cost in the healthcare system. If you are someone that suffers from a chronic disease, you often have comorbidities associated with that chronic disease. If you are stable, those lessen. It's really that simple. If you are stable on your medication, you go to the hospital less, you go to the doctor less, you drive down costs. So, in the healthcare space nationally, we hear a lot of arguments about, having healthy people in the healthcare system, making sure to drive down costs. To me, this aspect of this bill is one of the most important steps states can take to drive down costs, whether it be in their Medicaid program, if the bill applies to that, or within the commercial exchanges. Stable patients drive down costs. So that's the bill. Well, what's the history of the bill? Well, we've seen a lot of this from this gentleman. This bill has been vetoed twice by Governor LePage. Most recently, LD 289 a couple years ago was vetoed very strongly. Unfortunately, we were not successful in the veto override there. The previous bill was much different than the current bill. And that's one of the handouts that is attached, is a side-by-side comparison. And I think if you take a look at that for 2 minutes, you'll see this is a completely different bill. Previous bill, while well-intentioned, was a lot shorter and broader and did not have the specifics that I think that allow us to make some arguments in support of this bill, actually many of the arguments. There were many people, some people that are on the line today, that made very well-intentioned efforts on this bill and lobbied for the previous bills. I know I was one of those people. I was there for the failed veto override efforts on the last day of session, the last time this bill was before the legislature. But we weren't as organized. We weren't having these webinars. We weren't having bi-weekly calls where we coordinated hearings and testimony and talked about the political ongoings surrounding the bill. So we're off to a much better start to this time around, and I think have a much better chance. I should also note that I think that our bill sponsor is, one, very passionate about this issue, but politically a really good choice, and I'm pleased with that. So again, please take a look at the side-by-side comparison. I think it's important for everyone to familiarize themselves with that. So some lessons from other states. So, I think it's important to point out a few areas where we've had success. We've passed a bill in Illinois, Indiana, Missouri, West Virginia twice. Some of you may know that bill actually was deemed to be null and void because of an error in the administrative error and had to go through the process again. But that bill passed this year. Connecticut was kind of the original state where this issue popped up, and actually 3 different pieces of legislation passed on step therapy that combined to be a decent set of protections. Kansas in the Medicaid has passed this bill. California has taken its own kind of attempt at protections. It's still yet to be seen how those will work out. And recently, a couple weeks ago, Arkansas passed a kind of a little bit watered down version of the bill, but still some patient protections there. But then, as you'll see, let's see here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, at least other states that were considering this bill this year. And a lot of these states are still alive. Iowa's about to be on the governor's desk. Texas is looking great. Florida is inching along. Unfortunately, this is just very recent, so this map needs to be updated, but the Oregon bill has not advanced. Utah has not advanced, but still some hope in some other states like Colorado for some passage. Ohio's going strong. Rhode Island's looking good, as many of you know from that hearing a couple weeks ago. So a huge effort across the states on this issue. A lot of your organizations, for those that are on the phone right now or on the webinar, are involved in these campaigns. Your chapters are involved in these campaigns. I would encourage you, if you need some more background, to reach out to those chapters in these states where we've had success and talk to them about some of the lessons learned. So lessons from other states continued, right? So as we've discussed, health plans will argue that there's already an internal process in place. We know how to counter that. We know how to talk about that. We have data to talk about that. We can talk about the inconsistency across the plans. We know how to address that. This is in jest, $1 billion trillion. So every state we go into for this bill, we hear a new, grandiose, always very large and very well rounded off with lots of zeros number about how much this bill is going to cost the state. And when we first heard one of those numbers, I think it was 500 million in North Carolina. I don't know if the legislators were as tuned in to challenge that number. And we challenged it without much success. But as campaigns have continued, legislators have started to really wise up to this. And in particular this year in Utah and in Rhode Island and a few other states, Florida very recently, we've heard legislators hitting back at insurance companies and saying, where does that number come from? And I'll use Florida as a recent example. So there was a hearing in Florida on the step therapy bill recently, and the representative from one of the insurance companies came to the podium and said, this bill will cost X amount of millions of dollars. And the chairwoman of the committee said, well, thank you, sir. I've seen that data, but I've seen that number, but I haven't seen the data behind it. Have you seen the data behind that number? Well, yes, I have. Okay, well, what did you see? Well, I saw the memo. Oh, well, did you see the actual data behind it? Well, no, that's proprietary. Okay, so we know that oftentimes these are numbers that frankly are just pulled out of thin air. In Utah, we got them to admit that basically they just went back to the state when they drew up a fiscal note, went back to the state's PBM to get the data. And even they weren't allowed to see the actual data because it was subjected to privacy laws. So we haven't really seen a fiscal note or a summary of proposed costs that is really validated by any real data or, frankly, well thought out. And our counter to that is always, again, going back to the stability aspect. When you treat patients properly, you drive down costs. There's a schizophrenia study that came out of the Georgia Medicaid program a few years back that points directly to this. And what that study showed was that when step therapy was utilized within the schizophrenia space in Medicaid, they did save money up front on drug costs. Where they lost money was on return visits to the doctor and inpatient and outpatient services. So, you know, they saved about, I think it was $15 in drug costs, but they expended over $30 more in services. So they ended up losing money in the back end. And oftentimes we'll see kind of siloed arguments about cost. So it's important to come in with that Georgia Medicaid study. It's important to come in with talking points about the siloed nature of the number and talk about how stable patients drive down costs. One of the other things we've learned about this campaign in other states is that this really is a bipartisan issue that makes sense. And frankly, some of the more progressive states in the country have had more trouble passing this than some of the more conservative ones. For Republican legislators that are looking for an opportunity to take and I know we're in a new administration, but who are looking for an opportunity to take action on healthcare access issues that are in no way associated with President Obama or the Affordable Care Act, this kind of bill provides them that opportunity. It also, when we're elevating the patient voice, which I'll get into in a second here, and we're speaking with legislators and we explain what step therapy is, we explain what our bill does and what how the current system is operating, they seem to have very much so an aha moment and say, yeah, that makes sense. That makes sense to me. You can have my support. And this is across the aisle. Again, you know, the climate in Washington right now surrounding healthcare is so volatile that states are looking for any means possible to provide an opportunity to provide better healthcare access, to ensure that patient protections that may be in the ACA are codified in a sense, and again, our bill provides that opportunity. What else have we learned from other states? Well, I know I don't have to pitch this to this audience that much, but elevating the patient voice is very important. And again, we'll talk about it in a moment. There's a hearing coming up on the 25th of April, and I know that by the time some of you watch this, that hearing will have passed, but there are still going to be many opportunities throughout this legislative process where we need to elevate the patient voice, and we need to elevate the provider voice. The doctor's voices obviously very much matter. So please start recruiting, right? Start getting those patients that are ready to come to your lobby days and that are ready to start telling their step therapy stories and their healthcare access issues. because, you know, as government relations professionals, even though most of us are essentially white hat lobbyists that work for nonprofits, we're still viewed in a certain light. And so it's important for us to get the constituents, the actual patients, the actual doctors in front of the legislators, and that's when we've been most effective in other states. I can tell you in certain instances, and I would say New York, and Melissa, who I mentioned before and highlighted her story, we kept Melissa engaged all the way to the end of the process. And I mean, she went to the governor's office with us and sat down and helped negotiate bill language and explain why the bill was important very far into the process. And that's usually a time period where those people aren't seen in the room, and it's more the lobbyists, right? We kept those people in the room throughout the process, and I think that's part of the reason we had success there. So what can you do to help? Bonus points for anyone that can identify what state house this is. But I picked this picture because I like to say we all need to get out there and pound the marble in the state houses. And that's something we need to do. We need to get out there, and we need to be in Augusta. We need to be there as much as possible. I would ask that if you have lobby days coming up, I know some of you have a lobby day tomorrow and are making this a priority issue. If you have lobby days coming up, put step therapy on your list of issues that you'll be talking about legislators in Maine. Help us to identify patients and physicians, as I mentioned. Contact us, right? If you're not a part of the coalition, you'd like to join, we'd love to have you. Write, call, visit. Again, get there as much as possible. Write letters. You know, we have that hearing on the 25th. Reach out to me. Again, my contact information is in the beginning of the presentation. Reach out to me. We'll help you submit letters and support to the right people and in the right committees, and we'll get you involved. Again, we need to get as many people engaged as possible early on in this effort to ensure that we have the highest chance of success. Okay, that's all I have, and I will take questions if there are any. Let me take a look at the chat here. So one of the questions we got is what kind of fiscal notes have been attached specifically in other states? And so I'll mention really quickly, you know, we had a fiscal note in Utah that was attached that I think was really easily defeated based on some arguments we made, and that fiscal note in North Carolina. But in states like New York, where we actually have found out the bill was applicable to Medicaid, we did not have a fiscal note attached. And that's the second question I have is the bill applicable to Medicaid? And in this instance, in Maine, the bill will not be applicable to the Medicaid space. Checking here for any other questions. All right, I'm going to wrap it up unless I see any other questions added. Again, thank you everyone for joining the webinar today. This webinar has been recorded and will be distributed to the entire distribution list, to the coalition, and probably to other people as well. It'll be posted on steptherapyinfo.com. And please feel free to reach out to me personally or to Hillary Schneider at ACS if you have any questions about our effort or how you can get involved. Amy, you can stop recording when I'm done speaking. Again, thank you everyone for joining us this evening. Bye-bye.